The natural history of mantle cell lymphoma is the same with the natural history of lymphoma and the myeloma overall, the same with hematologic malignancies. So what is the natural history of mantle cell lymphoma? It is a repeated cycle of remission, relapse, and this can keep repeating for 5, 10, 20 cycles, 20 cycles. So, however, unfortunately, with each repeat cycles of relapse, the efficacy would drop further. Resistance, this is due to resistance gets further. The more you treat them, the more resistant they become, the lower the efficacy. Until the end, the efficacy drops to 0 because the resistance is almost 100%, and then we lose the patient to mantle cell lymphoma. So either chemotherapy or chemo-free therapy cannot cure the high-risk patients. Yes, you can put them into a remission for a period of time, but inevitably they would relapse. Every time you relapse, you put them into another remission using chemotherapy or chemo-free therapy or targeted therapies or combination or new trials, but they would again relapse. So what is our approach? Before CAR T cells, we do not really have any effective means. We use the allogeneic transplantation. We're able to put some of the patient into a long-term remission, but at a heavy price of mortality. So patient may not even survive the allogeneic transplant in a quarter to 1/3 of the time, to 33%. That price is too dear, and also the allogeneic transplantation is not readily available to the majority of the patients until we actually started treating the patient with the CAR T cell therapies. I'm very, very excited that Tecartus or the CD19 KTE ZUMA-2 protocol data was used for FDA approval last Friday, Friday, and FDA approved the Tecartus, which is the KTE CAR T CD19 CAR T cell therapy for relapsed mantle cell lymphoma. This clinical trial is particularly included all the risk of patients. Their prior therapies are prior 3 therapies. Many patients has TP53 mutation, blastoid, pleomorphic, complex karyotype, all that. The overall response rate is 87%, as the CR rate is 62%. This is the basis of the FDA approval. The side effect, we only with the CRS toxicity, the neurotoxicity profile are very, very favorable. And we did have some cases severely affected by CRS, 1 case, and 2 cases from B-cell aplasia infections. But overall, this brings hope to the high-risk patients, because why? And according to my ASH presentation in December 2019, about a big fraction, approximately almost 50% of fraction of patient has 2-year follow-up data at that time, and the sum of the patient, about 40% of patient, their curve are flat, and they looks like few patients are relapsing. So this is very encouraging. The curve so far appear flat, and of course, and at that time we only have 12 months of a median follow-up, with a fraction of people exceeded 24 months. But in this coming ASH in December of 2020, in the middle of the pandemic, we're going to present the more follow-up, more than 1 year follow-up, a very good longer follow-up data at the ASH 2020. So please come to see our data at that conference, either in person or virtually.